Well, good evening and welcome everybody. It's a new experience for all of us, I think that's fair to say. My name's Jonathan Hayes. I'm the clinical chair of the Bristol, North Somerset and South Gloucestershire Clinical Commissioning Group. And 12 months ago, we held our AGM on MS Teams for the first time, and that was an interesting experience. And who'd have thought that we'd still be in the constraints as a consequence of COVID-19? We've had to think of some very different and creative ways of presenting our AGM today. And I'm immensely grateful to Michelle Smith and to Katie Groves, who have been implementing this for us and been working on it for several months to make sure that we get this right today. To really ensure that we can properly present our AGM to the members of the public who are interested in our business. And I'm very grateful to you for joining us this evening and for giving up your time to listen to a presentation of all our achievements over the last 12 months. Interestingly, I think this is the first time members of the governing body have been together probably for about 16 months. So that's a real demonstration of how radically different our lives have been over the last year or more. And it's actually been quite interesting to see people physically for the first time. But we've had to do that giving consideration to being COVID secure. So all of the members of the governing body who are here in attendance this evening have had to have a lateral flow test. We're wearing masks as we move around the building, and there's hand sanitizer available to everybody. But we felt it was important that we actually had the opportunity to sit down together as a governing body and to hold this, which will be sadly our last annual general meeting for the BNSSG CCG before the system transitions into an integrated care system next year. We do have a number of apologies as a consequence of COVID, and either through illness or through clinical commitments, and I'll record those in a moment. But first of all, I'd just like to take you through a few housekeeping points with regard to how we're hosting the meeting this evening. And the first thing you'll notice is that when you've joined us, you will automatically be on mute. And the reason for that is that we need to avoid interference and feedback from the public address system that we're using. But also the chat bar's been disabled, really to ensure that people can focus on the presentations for consideration of accessibility. People who use word reader software, it can be quite disruptive if the chat bar is active. So we've disabled the chat bar as well. But we do very much want to hear from you, and if you have any questions that you wish to pose to the governing body, either as a consequence of the presentations that you'll hear this evening, or indeed if there are other questions that you want to ask about healthcare delivery, then we do have an email address, and excuse me while I just read this out to you. The email address is bnssg, standing for Bristol, North Somerset and South Gloucestershire, so bnssg.communications@nhs.net. So bnssg.communications@nhs.net. So if you have any questions that you wish to pose to any members of the governing body this evening, then please do email us in. We do have an opportunity for questions and answers towards the end, and we'll deal with as many questions as we can. Often people will have similar questions, so we'll try and group them into common themes so that we can hopefully answer as many questions as possible. And then the other thing to say is that there are no fire alarms scheduled this evening. So if a fire alarm does go off, that is actually a genuine alarm, and we will have to evacuate the building. So in that situation, we'll call the meeting off and reschedule for a future date. But you can be reassured that you can stay where you are, because the danger will be here and not at home. So we have a busy agenda scheduled for this evening, but first of all I'd like to introduce the members of the governing body who are with us this evening. First of all, Julia Ross, who's our Chief Executive, and John Lund, who's our Deputy Chief Finance Officer. Unfortunately, Sarah Truelove, our Chief Finance Officer, was unable to join us at short notice this evening, so John has very ably stepped in to replace her. John, thank you very much indeed. And then we have David Jarrett, who's our Area Director for South Gloucestershire and for Bristol. And sitting next to Dave, we have Dr. James Case, who's the GP Locality Representative for South Gloucestershire. I have apologies again at short notice from Deborah El Said, who's our Director of Transformation, who was scheduled to join us but is unable. So next I have Alison Moon, who is our independent clinical member registered nurse, is your formal title, Alison, isn't it? Thank you. And Colin Bradbury, who's our Area Director for North Somerset. We have Professor Peter Brindle, who's our Medical Director, and Dr. Matthew Cresswell, our GP representative for North Somerset and Woodspring. Rosie Shepherd, our Director of Nursing and Quality. Dr. Kevin Haggerty, our GP representative from North Somerset, Weston and Wirral. I may have got these in the wrong order as far as the camera's scanning around now, but apologies, it was a steep learning curve for me. And then I have Dr. Nick Kennedy, who's our independent clinical member and consultant anaesthetist secondary care doctor, and Lisa Manson, our Director of Commissioning. So apologies if they appeared in the wrong order on your screen. I'm hoping that the editing suite were on their toes and were able to accommodate my dancing around. I'd just formally like to record apologies from Dr. Kirsty Alexander and Dr. Julie Boardman, from John Cappock, Dr. John Evans, Dr. John Rushforth, not Dr. John Rushforth, just John Rushforth, and Sarah Talbot-Williams, who none of them are able to join us this evening. But we are quorate for the purposes of approving the annual report and accounts, and thank you, colleagues, for your support and attendance this evening. You will also see on the agenda that we formally acknowledge declarations of interest. I'm not proposing to go through those this evening, but they are registered on our CCG website. The professional and commercial interests of any members of the governing body are recorded there, so I would refer you to peruse those at your leisure should you so wish. So before moving on to the business of the minutes, I think it's fair to say that it has been another unprecedented year, and we've all had to get used to very, very different ways of living and working. And I think this is an opportunity for me and for the governing body to say thank you to our patients, to members of the public who have worked really closely with us to not just keep themselves safe, but to keep their friends and neighbours safe. And you'll hear a little bit later on about the work that we've done around COVID vaccination. But vaccination uptake has been fantastic locally, and it really is an important enabler, an important key tool in protecting other people and preventing the spread of infection. But also the continued use of infection control measures, wearing face masks, hand sanitizer, particularly in health and social care settings, because we do need to make sure that we're protecting our vulnerable patients as much as we possibly can, and I thank you for your cooperation with that. And I think it's also fair to say that I've been a GP now for almost 25 years, and I cannot recall any time where the system has been under such great pressure. As we've come out of lockdown, the demand on services has escalated exponentially, and I think it's a really important time to actually acknowledge, pay tribute and thanks to our excellent staff across the NHS and social care who really have worked tirelessly over the last 18 months, and their resilience is incredible. And I just want to say thank you to all of you for your continued commitment to patient care, for your skill and your dedication, but really primarily for caring for the patients that we serve. There's a number of positive things to have obviously come out of COVID, and you'll hear a lot about those very shortly, particularly with regard to the approach to population health medicine and the evolution of integrated care partnerships and how organisations are working much more closely together to optimise care for patients. But before we go into the presentations, the next item of business on the agenda is to acknowledge the minutes of the AGM from September last year. As I say, it was a virtual MS Teams meeting, and in some ways that was a bit easier because we could see our audience, whereas this evening we're interacting with you very distantly and very virtually. So I hope you're laughing at all my jokes and nodding encouragingly in all the right places. I can't see that, but I do have the pleasure of the company of the governing body here. It is an unusual and hopefully a situation where in future annual general meetings we can meet physically again and have better interaction with our public. The minutes of that meeting did go to the October governing body, and they were duly approved as a true and accurate record, and were accepted as such at our October meeting. So the minutes of this AGM this evening will be taken to our October 2021 governing body meeting for approval. So you've heard enough from me. I will stop talking now, and I will pass the baton over to John Lund, as I say, our Deputy Chief Finance Officer, who is here deputising for Sarah Truelove this evening. And John will talk us through the annual report and the accounts for the financial year 2020 to 2021. John, thank you.
Thank you very much, John, and good to see you all both virtually and in person here this evening. As John said, I'm going to spend a couple of minutes drawing out some key facts about the CCG's financial position and some of the key insights that were reported in our annual report and accounts that have been published on our website. Pleased to begin that by reporting that in terms of the CCG's key primary financial duties, they were all met in the financial year reported. So we maintained expenditure within our budget, and in fact the CCG did end the year with a £20 million surplus, which was actually representative of an inability to spend money as COVID sort of dominated the agenda, and there was some slippage on some of our investments. £20 million is 0.39% of the total spending that was made. I'll also draw out their running costs, which refers to our administration. So we have a specific limit on our spending on administration as opposed to on delivery of healthcare, and we also met that budget. Should recognise that it was a year like no other, and in achieving those targets, we did receive some additional financial support from the government to recognise the emphasis of COVID in particular on our services. Our auditors, Grant Thornton, issued an unqualified opinion on our financial statements as well, which suggests they represent a true and fair record of our accounts. Now, underlying all of that, there is the CCG has historically overspent on its budgets, and in previous financial years, including from the legacy organisations, has overspent an accumulation of £117 million. The government and NHS have made no request on us to repay those funds in the short term, and discussions ongoing with government, but I don't think we should lose sight of the long-term challenge back to financial sustainability. As John eloquently described, and we will all recognise from our personal lives, it was a year like no other. And I don't apologise for saying that was also true of the finances of the NHS and the role that finance and commissioning colleagues had to perform through this year. So I want to take the opportunity to set out what some of that meant for our finances and for our operating environment over the year. So COVID-19 pandemic clearly was the driving force of change, but whilst we would recognise the direct cost of care for COVID-19 patients, as well as the mass vaccination programme that has followed that, and that could be treating more people in an intensive care bed, but it could, as I said, also be about vaccination or home oximetry services. We also saw a significant impact on the financial arrangements on other NHS services. So demand for some services went up and the amount of spending had to go up. In other services, demand either went down or we were unable to meet those needs in full as staff, resources and expenditure were redeployed to manage the pandemic. So that saw some significant change. We also, as a consequence, saw some changes in the financial performance regime. So I've already mentioned the fact that we received some additional finance support from the NHS centrally and central government, but we also worked in a constantly evolving financial regime and had to be very flexible through the year and adapt to changing circumstances, as we all did in our personal lives. I think we're proud of the ability to maintain underpinning financial control during a period of such change. You'll hear more later about the impact on clinical services, but we also undertook a lot of progress on the transition towards integrated care services, and it's an example of where the COVID-19 pandemic has probably accelerated change in the NHS. From a finance perspective, that's changed the way we've made decisions on how we spend our resources within the NHS, working in much greater collaboration with our partners, including large NHS trusts in BNSSG, managing, for example, the BRI or Western General Hospital, but also in a more integrated way with local authorities and integrating how we work with primary care colleagues and secondary care colleagues. The NHS moved from an environment of some element of competition within the NHS to a far more collaborative style of management. Put the final note on there with respect to, I think, caution for the reader should be taken in comparing the current financial year's accounts to previous years, because of some of the rather obvious change I've pointed out. We'll spend a few times talking through some of the headline facts and figures, which I think would be of interest to the general public. So the CCG overall spends on behalf of the residents of BNSSG about £1.6 billion in the financial year 20 to 21, and that equates to an average expenditure of £1,573 for every individual within our community. The bubbles represent the key areas of expenditure: acute services, referring to essentially hospital services, primarily South Mid Hospital, Bristol Royal Infirmary and Western General Hospital. Primary care co-commissioning is our NHS internal language for the core family medicine general practice offer to our residents. Primary care services then refers to enhanced services that our GP colleagues provide on top of that core offer, as well as the expenditure on prescribing of medicines for our residents. The small blob is our administration expense. Hope that didn't make you all go too dizzy. I thought it was important to highlight some of the specific investments we had to make to manage COVID-19, which I'm sure will be of interest to the general public. So there's some headlines there. To give you three examples of expenditure, early discharge was a significant investment, both from the NHS together with our local authority partners in accelerating the discharge of people from hospital, in some cases into the care home sector, or to receiving more care at home, clearly with a view to creating extra capacity in hospital and ensuring that people's needs are met and as close to home as possible. Demand has risen steeply in mental health services, so an illustration of that would be the pressures on young children, school-aged children, particularly as a consequence of lockdown and a lack of the pastoral support from schools. So further services were invested to meet those needs and bringing forward some of the investment we'd planned over the next couple of years. Additional patient transport activity, so as a consequence of social distancing measures, a patient transport ambulance service was unable to take as many people to their hospital outpatient appointment in the same vehicle, and therefore had to deploy more vehicles to ensure that people could still get around. So as the year went on, we found the impact of this throughout our expenditure budgets as well as our services. My final slide makes reference to the year we're in and the year ahead. And to put some of this into further context, so the CCG in its last year of operation does expect to reach a break-even financial position for this year as well, albeit there remains an element of temporary financial support to the NHS as we move through the pandemic. What will be essential for us as we move forward, and what we're really grappling with now, is building on the productivity and efficiencies created by the COVID response. For example, how general practice has adapted to different models of triage, and hospitals have had to think about how they reconfigure their estate and the way of running outpatient services. We transition again into the new integrated care system finance framework. As I referenced earlier, that's largely about changing the way we make decisions about how we spend our precious resources within the NHS. We have to make a return to the pre-COVID long-term plan and financial plan. So once some of the top-up support is removed, we will have a challenging financial plan, but we also had an ambitious set of investments planned. And the key issue will be ensuring that we can get back on track with that agenda, whilst also managing the response to COVID and the recovery, for example, the waiting list backlog that we found. And as we talk, we are beginning to process and understand the government's comprehensive spending review and some of the financial settlement for the NHS and social care that was announced last week. One day moves into the other. Thanks very much. I've talked you through some of the facts and figures and the context in which we are operating now. Now, hoping the clicker works, going really proud and delighted to share with you a video of some of the highlights of our year.
Working in partnership with patients, clinicians, our communities and partners, we continue to shape better health for everyone living in Bristol, North Somerset and South Gloucestershire. Here are a few highlights from our year. 6 integrated care partnerships, or ICPs, were established for Bristol, North Somerset and South Gloucestershire. ICPs will deliver care at a local level, responding to the needs of local people. Our homeless health service provided drug and alcohol addiction support to 4 times more people than usual. A new community pharmacist service launched, providing prescription-only medicines for people with common health conditions, so GPs could spend more time with patients needing consultations. A new integrated frailty service launched in North Somerset, supporting older and frail people to get home from hospital faster and receive ongoing proactive support in the community. A new service allowing GP receptionists to refer patients with minor illnesses for a pharmacy consultation launched. Over 4,000 patients were seen by pharmacy teams under the pilot scheme. Following its success in our area, the service has been commissioned nationally. We partnered with local volunteers to make a series of COVID-19 information videos in 13 community languages, including Arabic, Polish and Farsi. 200 local people joined us at 4 listening events to share their experiences of healthcare during the pandemic. Their feedback shaped the reintroduction of routine services, including planned hospital procedures and operations. Our 24/7 Support and Connect mental health helpline launched, providing immediate emotional and practical support to people in need. Video and online consultations, alongside face-to-face appointments, were available at all GP practices after fast-tracking the introduction of digital GP appointments. Alongside our staff, we developed a comprehensive staff wellbeing programme to support people in both their personal and working lives, and received an HSJ Award nomination. Our NHS 111 service, offering urgent health advice, was enhanced with more input from GPs, nurses, emergency dentists, pharmacists and other healthcare professionals, providing faster access to the right care. Using design methods, we partnered with parents, carers and professionals to improve access to information for children and young people with special educational needs and disability. An innovative flu campaign resulted in 80% of over 65s in our area getting vaccinated, and high uptake among the most at-risk groups. A focus on learning disability saw 69% of people, up 13%, attending their annual health check, contributing to better physical health outcomes. The Healthier Together partnership for Bristol, North Somerset and South Gloucestershire achieved formal integrated care system status, reflecting the huge efforts made by local organisations to collaborate in recent years. The COVID-19 vaccination rollout began in December 2020. 98-year-old Jack Vokes was the first person in the area to receive the vaccine at the Southmead Hospital hub. 19 GP-led sites opened, vaccinating people over the age of 80, as well as colleagues in our community services and care home workers. A 12-month contract with UK Biobank, a large-scale biomedical database and research resource, was agreed, boosting local hospitals' diagnostic testing capacity by 15%. We opened Ashton Gate Stadium as a super vaccination centre and hosted Prime Minister Boris Johnson to mark the occasion. And local pharmacy teams also began vaccinating, further increasing the number of local sites. Bristol Royal Infirmary and Western General Hospital opened as hospital hubs to vaccinate those most vulnerable and our frontline staff, increasing capacity and pace of the vaccination programme. The launch of our oximetry at home service saw people in high-risk groups given devices to monitor their blood oxygen levels from home. Patients could recover at home confident of increased medical support if needed. The new service helped clinicians manage the surge in COVID-19 cases, and to date, over 1,500 people have been supported in this way. The Safe Haven Crisis Support Service opened its doors for face-to-face support in Weston-super-Mare's town centre, providing a safe space for people in emotional distress. We launched our Inclusion Council to ensure the CCG's workforce becomes more reflective of the diverse communities it serves, and to create a culture where everyone can thrive. New technology brought families and healthcare professionals together to provide virtual assessments for people with complex needs, allowing people to access specialist support from their own homes. A major project to refurbish Avonmouth Medical Centre was completed using funding from NHS England and Improvement Estates and Technology Transformation Fund. Our new integrated community mental health service, developed alongside people with lived experience of mental illness, was approved. The new service puts the person at the centre and wraps support and care around them, with all health, community and social care providers working together from one plan. The COVID-19 vaccination rollout expanded, informed by the contributions of community, voluntary sector and faith leaders. Vaccination clinics were held in places of worship, community centres, local shops and parks. An online language hub was created with vaccine information and resources available in 22 community languages. Our public consultation on improvements to stroke services launched. People with lived experience, clinicians and staff worked together to design the proposals. The proposals are designed to ensure fewer stroke deaths every year and improve long-term health outcomes. We partnered with gyms across Bristol and South Gloucestershire to offer people with osteoarthritis free access to Escape Pain, a new tailored exercise course. A review of mental health services for children and young people led to Off the Record being commissioned to provide mental health support and information to young people aged 11 to 25 across the area. The partnership approach to improving COVID-19 vaccine uptake in diverse communities was highly commended by the judges of the Florence Nightingale Healthcare Data Awards for 2021 and shortlisted in the HSJ's Race Equality category. Thank you to the incredible people, partners and communities who have contributed to our work in 2020 and 2021.
Well, good evening. I'm Julia Ross, Chief Executive of the CCG, and I feel quite emotional listening to that video just to see the range of the things that we've achieved this year as a CCG, but very much working together with our partners across the system, both in the NHS, in local government, and of course with our voluntary and community sector leaders. It's been a good year whilst being such a difficult year. Now, of course, responding to the pandemic has been a very critical focus for us this year, and we've had to adapt as the pandemic has changed around us. Vaccination became a mainstay of our work this year, And whilst the NHS has been open for business throughout the pandemic, of course we have had to really focus on restoring services as the country has begun to come out of lockdown. But we're still very much living with the virus, and we continue to treat people with COVID-19 every day in our hospitals. We see the increased demand for other services as a result of people not taking up care during the pandemic, and so we're having to do more for people every day. Staff across our system continue to do a fantastic job in providing safe and effective care in what are still difficult circumstances. But despite that, as you could see from that video, we have done a whole range of things to improve care for people in our community. And I couldn't be more proud of some of the things that perhaps don't get headline news. Things like people with learning disabilities getting much better access to physical health checks, which is so important to keeping them well and healthy. Things like improving services for children with special educational needs, a part of our community that perhaps we don't focus as much on as we need to, and yet these are our future, and it's really important that we do that. And even the significant increase in the flu uptake programme is something that we're really proud of. And as I said, not all of these things are in the headlines, but all of them really matter for the people of Bristol, North Somerset and South Gloucestershire. This ability to change whilst remaining true to our mission will stand us in good stead as we look to the future. We have a huge opportunity as we transition to become a statutory ICS to accelerate the progress that we've made in improving outcomes, reducing inequalities and ensuring services that genuinely fit in with people's lives together as a partnership. At our final AGM as a CCG, however, we want to reflect not just on this year's achievement, but to take the opportunity to look at our wider legacy and what that means for the future. Now, I remember a couple of years ago in our AGM talking about the 3 Ps, talking about how we in BNSSG are driving value-based healthcare, ensuring we can get the very best outcomes for the people we serve from the resources that we have. And our 3 Ps have underpinned everything we've done: people, place and partnership. We talked those 2 years ago about moving from what's the matter with you to what matters to you. And we have spent a lot of time and energy making sure that we can really understand the things that matter to people, from the individual person, understanding what matters to an individual, understanding what matters to the communities and people we serve in local areas, what matters to a particular patient or people groups, and also then what matters across our whole population, which is quite diverse. Value-based healthcare creates better outcomes for the individual, communities, and for the healthcare system because it becomes more efficient and we become more effective in meeting people's needs. So the first of our 3 Ps that we're going to explore tonight is people. And people are at the heart of everything that we do in BNSSG. I'm really excited that we're going to hear from colleagues who have been working on our population health management programme, and you're going to hear how we've been using population information to help us design better care for the people we serve.
Hello, I'm Dr. Charlie Kenwood. I'm a GP in Bristol and I work with the CCG on making sure that we meet the health needs of our population and make best use of the resources that we have available. This is also known as population health management, which really is about the way that we use our joined up health and social care records to improve the health of our population and make sure that our services are delivering the best value possible for the people that we serve. We join up the health and social care records from lots of our partner organisations, from GP surgeries to hospitals, to our local authorities, to our mental health providers. We put all of those into one big data set, which means that our data scientists and analysts can work on this really rich set of information that just has much more data and information available to us than we've ever had before. As the pandemic unfolded, we used our local data to forecast how many hospital beds we would need for people with COVID. So as well as making sure we had enough hospital beds for people that needed it, we also made sure that we had a safe and effective service at home for people who could be at home. And that's when we introduced oximetry at home.
So oximetry at home is a service for people who are confirmed positive with COVID-19, and they will be given a pulse oximeter at home to measure their oxygen levels and their heart rate. These then get monitored by clinicians twice a day to keep an eye on any sort of drops in their oxygen levels or anything that we'd be concerned about, to either take them into hospital or get a medical review or be kept at home and monitored safely.
Really, we didn't know what was going to happen with this virus and how far it was going to go. I was somewhat frightened in one way because I didn't know what was to come.
I felt devastated. I didn't know if I was going to be able to cope with him if it got really bad. And of course our sons were unable to come and see us.
So for people like Martin and Wendy, and for many others, they generally like being at home if they can.
So patients were selected to come onto the ward if they're deemed as clinically vulnerable, or if a GP or a healthcare professional deems that they need monitoring because of their COVID-19.
COVID oximetry was a way of keeping people at home safely. And it also meant then that we had beds in the hospital available for people who definitely needed to go in.
It was like a weight being lifted off my shoulders when I was told he would be on the virtual ward.
Well, they used to phone, I think it was twice a day. They gave us this little thing here you put on your finger, which gave them the readings they required.
So as a GP, when I've spoken to my patients who have been on that service, they found it really reassuring because they had somebody contacting them on a regular basis. They knew that we were all talking to each other and that we could all see the same medical record. So it was really reassuring for both patients and their families to know that this service was here for them.
Well, I did feel safer being at home because I had my wife here supporting me, and also it restricted the number of people that I was mixing with. I was sort of on my own with my wife, and that made me feel great.
We were fortunate enough to have vaccines become available to us. But very early on, we recognised that there might be a problem with the uptake of vaccines among certain communities. So we produced a map of our area, so Bristol, North Somerset and South Gloucestershire, that showed where different communities were sort of characterised by those things such as not speaking English as a first language. And then we used our flu data from this season's flu vaccination campaign to show that actually we were onto something here, and that the uptake of the flu vaccine was different depending on which area you lived in, and dependent on which language you spoke, and sometimes depending on which ethnicity you identified as.
So we carried through all of those insights and sort of built on them for the COVID vaccination campaign. And we've really listened to our communities. So I think we've built a lot of trust across the whole system with our communities. We've involved a lot of different people that we wouldn't have spoken to before. We've now got walk-in offers for people because a lot of the younger population don't like pre-booking appointments. They just like the convenience of going somewhere. We've also done far more sort of place-based offers for people as well. So pop-up clinics in mosques, in the heart of communities. So we've done lots of sort of clinics that have just been really tailored for populations in specific areas.
And we see some really encouraging signs from our data. So for example, we saw a gap in the over 65s open up between people who spoke South Asian languages or Somali. And that gap has come down to almost closed for the South Asian community and less than 10% for the Somali community. We're now using this for more than just our COVID response. Right now, we're working on improving our mental health services, and particularly our mental health services within the community. But what we're looking at right here on the screen is the record from just one person. Now, every dot on here is something like a GP appointment or a hospital appointment or an appointment with a mental health specialist. And as a GP, when I look at this sort of thing, I see an opportunity for us using all that resource in a better way to help that person. And so what we're moving towards is really trying to understand what matters to people as they use these services, being able to actually measure them, and then put them against this sort of data so that we know that we're investing in people's health in the right way. I think the biggest legacy from population health management is the partnership working that it's brought about. So when you bring these data sets together, when you look at information together that means something to all parties, people start to have a shared conversation about the shared problem. The thing I'm proudest about over the last year is the way that all of our teams, my colleagues, have all worked hard, worked together under the most immense pressure, but always with people's needs at heart, with their best interests at heart, and always trying to do the right thing for the people that we serve.
So you can see how better understanding our population's needs has helped us to support people much better. Great to hear from Martin and Wendy and just how much more confident and comfortable they felt in very difficult circumstances. At the very heart of all of this, is our focus on place. So the second P that we've been focused on since we started as a CCG is how we build more effective place-based care, partnerships at locality level that enable us to design services that wrap around populations and help keep them well. We set up 6 localities, our localities which have now turned in or are turning into what we call integrated care partnerships. But we've been on this journey now for some time, and there's some incredibly exciting work going on within the partnerships to think creatively about how they meet the needs of their populations. We want our integrated care partnerships to be available 24 hours a day, 365 days a year, to provide a safety net of care for complex and vulnerable people in our communities, and to make sure that wherever and whenever we can, we both help people stay independent, become more independent, and to stay in the community close to home when they need care. As was mentioned in that video, we've particularly been focusing this year on community mental health. And we published our so-called target operating model, and this is an image of that, where we're trying to think about how mental health services in the community might wrap around the people that we serve. This has been designed in partnership with local communities, and most particularly with people who have lived experience of mental health needs, and also with our clinicians. We've been able to design this fully integrated way of delivering care to support people. And while the overall aim and quality standards will be universal across Bristol, North Somerset and South Gloucestershire, recognising the different needs of different demographics, geography and the current shape of services in those areas, we are also targeting this to individual communities. It's really exciting stuff. And the first big test of the ICP model and the difference it can make. So we wanted to share it with you, and we asked our colleagues in South Bristol to tell us a bit more about what they're doing.
The integrated care system is across Bristol, North Somerset and South Gloucestershire. So the whole system is made up of 3 areas, which are 3 local authorities: Bristol, North Somerset and South Gloucestershire. There are 6 integrated care partnerships at more of a locality level, and 3 of those are in Bristol. And today we're going to talk about the South Bristol Integrated Care Partnership. It's a way of joining up different services together. Our vision is really about ensuring that we work together as partners and organisations in a really different way, so that the experience of the person, the citizen, the patient, is that they get the support they need when they need it, and they get it from their community, from their home, and that we really focus on people's well-being.
As a community development organisation, we basically get involved in just about everything that the community is interested in. And what excites me about the developing ICP is, one, it brings together a whole range of NHS colleagues and also people from the City Council. We've got people from public health there as well, and also from the community development team. And I think that adds a real strength. And then to cover the whole of South Bristol for the voluntary and community sector, we work in partnership with Knoll West Health Park.
I am responsible for the practice that I run, and that is about services provided for patients, or people I should say. I'm also a GP trainer, so I'm involved in education. Being involved as a GP partner is about having a voice in the system. What's really exciting is it's about completely throwing out the rule book and saying we can rewrite how services could look.
$160,000 people live in South Bristol.
South Bristol in itself is a really diverse population in itself, and I can only equate for my practice, I would say we have 0 to 105 of the length of longevity, but we have health deprivation and some child poverty. We've got affluence as well.
Yeah, South Bristol is a vibrant area to live. People think about vibrancy in terms of cafes, arts and culture, but also I think the more traditional Bristolian aspect of South Bristol is vibrant.
The communities tend to look after each other, so they're much more sociable in many ways. Because they've been there for multi-generations, they know each other quite well, and therefore there's a bit more of a community spirit. Okay, in the next year, we really want to including people from South Bristol in the development of the ICP and the sort of services and the way of working and the way that we're joining up, so they have a real voice in this. They are co-designing and co-delivering even some of this. And the other one is to really provide information to the population in ways that are accessible to them. We have quite a number of different languages, we've got different abilities to read and write, so it's not just around the written word. And the third thing that we're going to do is look at community mental health and how we're going to deliver that in a far more joined up way.
10,000 people in the whole of BNS or Bristol have serious mental illness, and that's schizophrenia, bipolar, psychosis. The greatest amount of mental health that tends to happen in the community is what we call low level. There is this massive population of people who have issues and they don't know how to deal with them, and they don't know where to go and get help.
And presumably the mental health issue is actually a consequence of something else that's driving them into that.
Exactly. Yeah. So what we're trying to do is trying to stop them reaching the point where they need, where they reach a crisis point, or their depression becomes so bad that they need to talk to someone about it, or that they need to go see a professional about it.
The new world will be that that person doesn't have to come to me. There is a service in the community, in their neighbourhood, where hopefully they don't get to that point because it has support for them to how to help with issues. There will be a specialist team of people, i.e. everybody from all the community providers who deal with mental health, because there are multiple teams involved in supporting an individual, so who are based all over the city, and what you want is really just for them all to be in one place where they can go to. That individual will know where to go, and when they go there, they'll have a conversation and they can say, right, let's see where this all comes from. Is this, why are you feeling so terrible? Is it a financial issue? Is it a housing issue? Most things tend to be non-medical, and it's like, well, we've got a team of people here who can help you with that.
You would have one plan and one point of contact. So if you needed support now or in the future, you would have somewhere you could go to get that support, and you would know what that support was.
We're moving very much into the well-being of individuals, And as we know that sort of the health aspect is about 20% of somebody's well-being, so 80% is all the other things in life, just as Indra was saying, it's housing, it's employment, it's just the basic needs of life. And that's where we can actually support the person in their community, in their context, and that's really important.
Yes, we are absolutely investing in care and support for people that live in South Bristol, and that is partly about the way that different services and organisations join up together to work differently together so that people can get the support they need without us having to refer to each other and go to lots of different organisations, but also about us actually investing in the communities themselves and supporting those communities and working with communities so that the community does feel stronger, and that includes investment in making that those communities feel safe, making sure that people have got adequate housing, they can travel to where they need to get to, that they can get the right advice and support when they need it. But also we recognise that the strength is within the people that actually live in those communities themselves. So we still have responsibility, but we're trying to engage and invest in those communities and those people so that they've got the best chance in life, really.
Thanks to colleagues in South Bristol for sharing that with us. And we chose South Bristol, but we could have talked to any of our 6 localities and have got just as exciting a sense of how all the people in our localities are working together to improve services and with their communities. So it brings me neatly to my third P, which is partnerships. I don't think partnership has ever been more important for us than it has been in the last couple of years. The pandemic has shown us that we simply can't help people in our individual silos. We simply have to work together. And that has, as Charlie said in the population health management video, that has really extended to communities. We've worked with communities this year in a way we have never before. I'm kind of ashamed to say that, actually, but we really have, and we've learned so much from working with communities and community leaders about how we can ensure that we drive out health inequalities from the work we do. And I know that's a legacy that will be taken forward into the integrated care system as that develops. The partnerships we've forged and will continue to build, they have been critical to everything we've done. So I wanted to take this opportunity to thank everybody who's been involved with our work in whatever guise, not just this year, but in the CCG's 3 years of operation. It would take me far too long to name you all, but whether you've contributed to the work we do as an organisation or as an individual, that contribution has enriched us. Community leadership and trust building has been a key factor of this year, particularly as you've seen with the vaccination rollout, where, as Charlie said, the delivery of the programme was co-led with our communities, and they guided issues such as where clinics should take place, how we should communicate accessibly for all of our population, all in the service of better outcomes for our people. I want to thank those colleagues particularly for your tenacity, your openness and willingness to share. This isn't just about engagement, it's about equal partnership. It's about power sharing and real participation, and we couldn't have done it without you. On this note, I also want to thank our vibrant voluntary community and social enterprise sector for the value they bring and will always bring in a much more integrated landscape. As we come together more, our voluntary sector is ever more at the heart of what we do. Thank you too to all our system partners this year and every year. To the people who have joined events, both online and offline, written to us, provided consultation feedback, taken part in our citizens panel, lived experience group or design workshops. Whether you got in touch to share your experience, hold us to account, shape a service, disagree with a decision, or help us to think differently. This is what partnership really means, and what stands us in strong stead as we look to the next chapter for the NHS, in which collaboration is critical. Thank you. We're now going to move to the question and answer session and answer some of the questions that you have asked us both before tonight, and hopefully some people have also sent in some questions this evening.
Indeed, and I think there were some excellent examples of some of the work that's been happening over the last 12 months. So I'm sure that will have stimulated a number of questions from the public. So Michelle, can I ask, do you have questions that have come in during the course of the evening?
Yeah, we've had a number of questions come in both before the event and during the course of it. So I'll take you through some of those. And like you said at the outset, John, we've tried to group them. And just to note that we will be publishing answers to any of the questions that we don't get to this evening on the website, and all attendees tonight will get the link to view those. So to kick us off, we've had a number of questions, quite detailed questions, about representation on the new integrated care boards. And a couple of those covered patient and public involvement. So the first question is it true that providers will be on the integrated care board but patients won't? And we've had a similar question in relation to the voluntary sector as well.
Okay. Julia, you're probably
Shall I take
best.
that?
Yes.
Okay. Well, of course, the integrated care system and the integrated care board are not yet established, and final decisions haven't been taken about who sits on boards and so on. But what I can say is that hearing the voice of the people, having our patients, public population and our voluntary sector at the heart of everything we do, I hope you've seen tonight, is something that we really believe in, and that will continue. As to the makeup of the board, we simply don't know about that just yet.
Thank you.
Okay, next question is, what is the nascent integrated care board's stance on ensuring transparent public tendering for contracts, despite the new arrangements not requiring them to do so?
Okay, thank you. As commissioning question, Lisa.
So obviously we're still going through the legislation at the moment, but there was a really helpful document published by NHS England and Improvement earlier on in this year called the Provider Selection Consultation. And what that does, it's about getting the right services for our population. And procurement, of course, and tendering is one of those options. Clearly, the work is making sure that we can actually work with partners to make sure that we're getting the services that are right, that meet our population's need. If that isn't the option that we need to do, we can always go to using procurement and tendering, and that is the likely implication as we move forward into the ICS, into the new legislation and its framework, and that's how it's kind of reflected in there. I think it changes the emphasis on procurement, but not necessarily the need to not procure.
And just to add, of course, the Integrated Care Board will be under the same duties, the Nolan Principles, so-called, the same duties of public life, to be transparent and open in the decisions that it takes.
Thank you. Okay, Michelle, next question.
While we're on this theme, we've had one come in the last 20 minutes asking governing body what they think the biggest challenge will be of transitioning to statutory ICSs from April.
Gosh. Well, I mean, from my point of view, I think maintaining all the good things that we've done and maintaining the what you might refer to as the sort of organisational memory in the transition across, so that we build on all of our successes and that we aren't starting again from scratch. And I think we are in a very good place in terms of the evolved partnership relationships and collaborative work that's happened across the whole system already. So I think we're in an excellent place to develop on that. Julia, do you have any other?
Yeah, and I think, you know, it's a difficult time to be focused on organisational transition because there's so much going on in our day-to-day business. So making sure that day-to-day services, you know, keep we keep a focus on improving recovery rates around post the pandemic, making sure that urgent care system is working effectively. So sometimes organisational change can be distracting, and being careful that we keep our focus on the things that really matter. And of course our staff. So it is always difficult for staff when the organisation they're in disappears and a new organisation starts. So it will be up to us as leaders to make sure that our staff feel confident and comfortable and happy even as we transition into a new organisation.
Thank you. Michelle.
Okay, next question is from a resident of South Gloucestershire. He said that he has just one bus an hour going to Southmead Hospital via a very difficult route, and many parts of the county have no direct service at all. What is the CCG doing alongside MBT and the council to ensure that patients and staff can get to Southmead on public transport?
Well, as if by magic, David, as the area director for South Gloucestershire, I can see you've been given the microphone, so looks like you're answering the question.
I'll give that a go. Thank you for that question, Michelle, and I hope you've had some insight into my response to the presentations tonight. As you can see, our absolute focus on partnerships, person and place within our integrated care partnerships are bringing organisations together to look at patient need and patient demand and really create services that best meet the needs of individuals and of populations. I've got the pleasure of being party to 4 integrated care partnerships, and it's been a pleasure to see the providers from our acute providers, our mental health provider, our community providers, primary care and the voluntary sector, and local authority colleagues in coming together over the course of this year to really look at services to make them accessible and better meet the needs of our population, and absolutely looking at access of services, including transport routes, is a fundamental element of that, and will continue to be part of the priority working for our ICPs.
Thanks, Dave. Okay. Michelle, any more questions?
Yes, we've got one on cancer services. So somebody has asked, when will the number of gatekeepers patients need to pass through to reach a consultant reduce to 1 or 2 rather than the current 4+? With the UK remaining the worst place in Europe to have cancer, this issue has become critical for the lack of early diagnosis.
Okay. Peter, thank you.
Yeah, thank you for the question. It sounds from the questioner you've had a less than perfect experience, and that's something that certainly we would all want to hear more about, me particularly. As medical director, I'd like to hear more about bad experiences so we can do something about it. It would be helpful to know a bit more about what we mean by gatekeepers, but the way things should work is that if someone has symptoms that could well be cancer, they should be able to see their GP, and the GP can do the assessment and then refer them on to our 2-week wait system, where they get to see a consultant in a consultant-run clinic and have all the appropriate investigations that they need in order to clarify whether or not they have cancer, and if so, what the treatment might be. So that's how it should work. Having 4 gatekeepers doesn't sound right to me, and I'd certainly like to know more about what that actually means so that we can understand it and do something about it.
So if that person would like to write into us setting out their particular experience, Peter, I know you'd be happy to respond directly.
Absolutely right, yes.
Thank you. Thanks, Peter. Michelle, any others that are coming through?
Yes, we've had a question on our public consultation into stroke services, just asking what the next steps to that are now the consultation is closed.
I'll take that.
Okay, thank you.
Okay, well, our stroke consultation has just recently closed. I'm delighted to say we've had a massive response. We way exceeded our ambition for the numbers of responses. I think it was 1,800 different unique bits of feedback, so that's fantastic. The next steps are that our consultation report will go to our governing body, I think in December. Michelle, I think I'm right in saying. And then we have to produce a final business case for NHS England to get final approval to go ahead with the changes, and that will happen in February. But thank you to everybody who responded to that consultation. And of course, right now we're taking all of that feedback into account in coming up with our final business case.
I'd just like to add my thanks to the team that facilitated that consultation, because having been involved in a number of the events myself, I know it was challenging and difficult doing that through a virtual platform, but actually it was run really, really smoothly and effectively, and we had some excellent feedback from patients with experience of services.
And particularly hard to do that in COVID. So, you know, having to try and get people along to online events as opposed to face-to-face and so on. So, yeah, particularly pleased with that.
Okay. Michelle, any more for...
Just checking what we've got. We've got a final question, I think, on blepharitis. So somebody's asked why blepharitis has been classified as a mild condition, with the result that all patients, even those with severe problems, are refused NHS prescriptions for the condition. And how many blepharitis sufferers were consulted on this?
Peter's grabbed the microphone already, so Peter, thank you.
Well, I guess like many conditions, blepharitis has got a range of severity. Sometimes it can indeed be very mild. It can be some itchy eyelids that one can manage at home with cleaning your eyelids and stopping build-up of infection. So it can be very mild. At the other end, it can be extremely debilitating with a very red eye, leading sometimes to ulceration of the cornea and visual issues. So it's got the full range. So in some cases it is mild, but in other cases it does need a prescription, and in some rare, thankfully rare cases, it needs a referral to an eye specialist. So I don't think it's not true to say that we can't prescribe medication for blepharitis. If it's severe and it needs chloramphenicol or an antibiotic of any sort, then it will be prescribed. If it is something that people get recurrently because it's an itchy eye condition, maybe related to eye makeup and the like, then we encourage people to learn how they can look after it themselves, so they can manage it themselves without having to call GPs or other services, so they're in control of their own condition. So it is a range from the mild to the severe, but where it's severe and needs treatment, people can get the treatment.
Thank you. Okay. Do we have any other questions? Or does anybody want to add anything to that? No? Okay. Were there any other questions that have come in through the email?
If you've got time, we've had one that's just come through.
Okay, yeah.
Which relates to children and health advice during educational healthcare needs assessments. And so somebody's asked, currently around 50% of children and young people do not receive health advice even when the local authorities request it. And that's a real concern for parent carers.
Okay, so that's a children's commissioning question, I think, Lisa. Thank you.
Thank you, and thank you for the question. And it was something that came to our attention over the last 24 months, I'd say. And so what we have done is, alongside our sort of commissioning of, and I kind of forgot the name of the DCO, what does it stand for? The Designated Clinical Officer for Children. It's when you spend your life in three-letter acronyms, you suddenly go, I actually can't remember what it stands for. We've actually invested in Sirona to have what we then called Associate Designated Clinical Officers. That role, that name has changed, deliberately to make sure that where we actually had children who were referred for an EHCP, that effectively the initial answer was not known to health. We actually then had those individuals make sure that they reviewed those EHCPs. They reviewed those to make sure that we can, if there are assessments that would be useful from health's perspective, but also to make sure that we have that wider and more comprehensive completion of the EHCPs. It's not perfect yet, but we are getting there, and so we're slowly seeing an improvement coming up to 80%, but I recognise that it has taken us a journey to get there, but we have deliberately invested to make sure that we have those 3 additional staff through Sirona who are all clinically qualified to make sure that we make sure we've got that wider aspect and that wider, more holistic health look at those children.
So thank you very much indeed. And Michelle, thank you for fielding the questions, and thank you to the members of the public who've posed the questions to us, because it's really helpful to have your feedback and your thoughts and your challenges to ensure that we're meeting your needs. As Michelle said earlier on, the questions and the answers will be collated and published on our website, so they'll be available for you to refer to, particularly if you put a couple of together in a sort of thematic question, then we will ensure that all of the questions are clearly and succinctly answered on the website. But if you have subsequently posted any questions, or if any questions occur to you after this meeting, then feel free, please, to post them to the email address, and we will endeavour to answer them promptly. Thank you, Michelle. So I think it's really important, actually. You know, we heard the presentations earlier on and saw the videos of emphasising some of our successes and achievements in the last 12 months. But actually, you know, none of that can be done. None of this can be achieved without our excellent staff that work in the organisation. And Julia talked earlier about the challenges of transition into ICS and ensuring that we nurture and support our staff through that. But all of the staff in the CCG have just simply been excellent in really, really challenging times, very challenging circumstances of work. And nevertheless, despite all of that, we've made so many achievements that you've seen earlier on. And I think it would be a great opportunity, briefly, to just show you a short video of some of the achievements that our staff are specifically proud of, their sort of personal achievements. And I'd like to just share that with you now.
Hi, I just want to say a really massive thank you to everyone who's been working so tirelessly in the area directorate and within the localities across BNSSG to really drive forward integrated care partnerships. You know, place-based working is the future. It's going to make things so much better for our patients and our wider population.
I'm Ruth Thomas, I'm Head of Locality for South Gloucestershire. I'm really proud of the Stokes Primary Care Network's Wellbeing and Recovery Service.
Hi. My name is Joe Paul and I'm Head of Locality for Inner City and East Bristol in the Area Directorate. One of the things I'm most proud of that our team has achieved this year is establishing a new service to support people who have mental health challenges resulting from COVID, but also for other reasons, with our system partners, Second Step and Nilari, taking some of the pressure off our GP partners and providing an excellent service for people within Inner City and East Bristol, and that's something I'm really proud of.
I would like to thank the Modelling and Analytics team, as well as the wider BI team and Fixed Directorate for enabling my secondment to run so smoothly this year.
Hi, I'm Fritha. I'd like to say a huge thank you to our stroke service user group and those with lived experience for all of their hard work and contributions in the stroke reconfiguration programme. The support given throughout the process has been fantastic.
Hi, and my name's Mark Hemmings. I'm Head of Transformation, Children and Families, and I lead on special educational needs and disability. I've really enjoyed working with local authority colleagues, both in education and social care, and the voluntary community sector, and particularly young people and their parent carers.
I'd like to thank everyone across the CCG for their fantastic knowledge of their subject areas and for always being helpful throughout the many years that I've been working here. I'd like to thank the midwives and doctors at St Michael's Hospital for helping deliver my daughter safely. They were incredible and I can't believe they do such fantastic work every day.
Massive thanks to Victoria Blizzard, Emma Moody and all of the mental health commissioning team for all their help to us at Transformation over the last year and being such great virtual colleagues. Thanks guys.
Hello, I would like to say a massive thank you to the MSK Service User and Carer Group, and we couldn't do the work without them, and I really appreciate it.
Hi, I'm Sian, and I'd just like to thank the mass vaccination programme, the very best example of an effective, supportive, cross-functional, cross-partnership team without hierarchies, focusing on achieving a common goal.
Hello, Sam Nolan here from the Infection Control COVID Tactical Cell. This is a big shout out and a huge thank you to Karen Oliveira, who has been leading the team and providing an outstanding infection control service to each of the local authorities across BNSSG.
It's been a phenomenal year in the CCG, and I'm very proud of my colleagues who have stepped up their efforts and worked closely with our partners across Bristol, North Somerset and South Gloucestershire to deliver health and care in such unprecedented times.
Hi, I'm Andy Coles-Driver, and I'd just like to say how proud I am of the MedSop team for all their work on the mass vax with the COVID vaccine. Also like to say a massive thank you to all my colleagues in the CCG for all the support they've given me, and you've really helped me get through a tough time. Thank you.
I'm Abby Saville. I'd like to give a big thank you and a shout out to everyone who's been involved in the CCG Wellbeing Group, and definitely proud that the programme of work as part of the Wellbeing Programme was shortlisted for 2 national awards.
Internally, the corporate services team went above and beyond to issue equipment to colleagues, to support home working, and also to make our office environments safe for those needing to access this space. Let me end by saying thank you to my team and to everybody involved in our work. Thank you.
I'm really struck by the not just colleagues in the CCG thanking each other, but actually thanking other people working in the system. And it really is a true statement of what we're achieving in terms of that collaborative work. I think partnership working was a natural progression that we were achieving and making progress with, but the pandemic has really catalysed that, and the approach to collaborative working across the system is fantastic, and I think it's a real testimony to the hard work of all of our staff, but also staff in all of the other organisations that we work with to help us to achieve our goals to improve the care for the patients that we have the privilege of looking after. I think it's also a good opportunity, as this is our last CCG AGM, to just record our thanks to colleagues that don't necessarily work with us now for whatever reason, but all of the people that have worked together and contributed to the successes of this CCG and the CCGs that preceded it in all that we've achieved to improve the health and well-being of our patients. And their contributions really, they were the sort of building blocks and the foundation to all of these successes, and will continue to help to move the system forward. And I think the other thing that I just wanted to say on behalf of the governing body really was to thank all of the executive team who are actually the driving force behind the CCG and get all of the work done on a day-to-day basis, but particularly to Julia, our Chief Executive, whose strength of leadership and vision has really been exemplary. And she truly always puts the care of our patients at the heart of everything that she strives to deliver. And that really stands us in great stead for the future as we evolve and the system moves forward into a statutory integrated care system, and really for transforming the care of the lives of the people that we serve. I wanted, on behalf of the governing body and the membership, to thank the executive, but particularly Julia, for a job really, really well done. Thank you. So that really just leaves me to say thank you to everyone who's joined us this evening. I think at the beginning I was told that there was something like 150 people who'd registered to attend this evening. Unfortunately, I've no way of knowing whether all 150 of you are here, but if you made it, then thank you very much for your attendance and interest this evening. The last 16 months have been strange with governing body meetings and all of that operating virtually through MS Teams, but we have been blessed with regular attendance from members of the public who have had the resilience to sit through our entire business and really sort of made it to the end and then challenged us with some really robust and really relevant questions. And we're just grateful that you care about the job that we do, and it gives us an immense sense of privilege to be able to do that job, to deliver healthcare to our population. But it is important that we do that in partnership with you, and your voice is always welcome in giving us feedback into the things that we've achieved, and hopefully continue to achieve. But I also wanted to thank the members of the governing body. As I say, this is the first time that we've been together face to face for a while. That isn't without a degree of nervousness, and hopefully we've been successful in achieving the infection control measures to ensure that that's happened in a safe way. But again, at the beginning, I said thank you to Michelle and to Kate for organising this evening. Kate particularly has just been brilliant in setting this all up, and I was really, really nervous before we started about how it was going to go. I hope it's gone okay. I will watch it back afterwards just to make sure and see how catastrophic my introductions were at the beginning. But it has gone relatively smoothly, I think, and I hope it's been well received by you. But all of the comms team have supported Michelle and Kate in delivering this. Jack and Will here this evening, and thank you guys for your support. And can I just say thank you to the team in the studio here at the TH Collective for making this a relatively straightforward experience for me. It's not an experience I've had before, but it has been more enjoyable than I thought it would. So thank you very much for helping that to run smoothly. Thank you to all of the speakers this evening, and to all of the brilliant people who've been involved in creating the videos and participating in those. And as I say, this is our last annual general meeting of the BNSSG CCG, but thank you very much indeed for your interest. Thank you for your attendance, and we wish you all the very best. Thank you for your support this year, and we hope you continue to support the ICS in years moving forward. Thank you.